If stool feels stuck in your rectum, and no matter how hard you push, nothing comes out, I want you to stop straining right now. Not in 10 minutes, not after one more try, right now. Because when stool is truly stuck, forcing harder is not strength. It can make the rectum more swollen. It can worsen hemorrhoids. It can cause tearing. It can make you dizzy. And in older adults, it can turn a painful bathroom problem into a medical emergency. You may feel pressure deep in the rectum. You may feel like the stool is right there, but it refuses to pass. You may sit on the toilet again and again. You may push until your face gets hot. You may pass only a few small pieces. Or, and this is the part that fools many people, you may leak watery stool and think, now I have diarrhea. But that watery leakage may not be true diarrhea. It may be liquid stool leaking around a hard blockage. And if you take the wrong medicine for diarrhea, you may slow the bowel even more and make the blockage worse. I am Dr. Adrian, and today we are talking about stool stuck in the rectum. What it is, why it happens, why it can be dangerous, what signs you should never ignore, what not to do, when to call a doctor, and how to stop this from becoming a repeated nightmare. This topic is embarrassing for many people, but embarrassment is exactly why people wait too long. And waiting too long is how constipation becomes fecal impaction. So before we go deeper, I need to be very clear. This video is educational. It cannot replace an exam. If you have severe abdominal pain, vomiting, fever, a swollen or hard belly, blood in the stool, black stool, inability to pass gas, inability to urinate, fainting, confusion, or you have not had a real bowel movement for several days and feel very unwell, get medical care urgently. Do not keep trying at home. Do not keep pushing. Do not keep taking random laxatives. Do not be embarrassed to ask for help. Doctors and nurses deal with this every day. Your safety matters more than your shame. Now let me explain what is happening inside your body. The medical name is fecal impaction. That means stool has become hard, dry, and stuck, usually in the rectum or lower colon. The rectum is the final holding area before stool leaves the body. Normally, stool arrives there soft enough to pass. The rectum stretches. Nerves send a signal. You feel the urge. The pelvic floor relaxes. The stool comes out. But when stool sits too long in the colon, your body keeps pulling water out of it. That is what the colon is designed to do. It absorbs water. The problem is that it does not know when to stop. So the longer stool sits there, the harder it becomes. Soft stool becomes firm. Firm stool becomes dry. Dry stool becomes hard. Hard stool becomes a plug. And once a hard plug is sitting in the rectum, pushing harder may not move it. Sometimes pushing only packs it tighter. That is why people sit on the toilet for 20 minutes, 30 minutes, sometimes longer, sweating and straining, but nothing changes. The problem is not effort. The problem is mechanics. A hard mass is blocking the exit. Now this usually does not happen overnight. That is the dangerous part. It builds quietly. Day 1, you skip a bowel movement. Day 2, you pass only a small amount. Day 3, you feel bloated. Day 4, you feel pressure. Day 5, you keep trying, but nothing feels complete. Then the rectum feels full all the time. You cannot pass a normal stool, and now fear starts creeping in. You wonder, is something blocked? And sometimes the answer is yes. Now let me tell you about a man I will call Henry. Henry was 74. He was private, proud, and not the kind of man who wanted to talk about bowel problems. A few months earlier, he had started taking a stronger pain medicine for his back. He also took iron tablets. He drank less water because he did not want to wake up at night to urinate. And because his back hurt, he walked less. Every one of those changes slowed his bowel. But nobody connected the dots. At first, Henry just felt a little full. Then he noticed his bowel movements were smaller. Then he skipped a day. Then 2. Then he sat on the toilet and strained, but only tiny pieces came out. A few days later, watery stool began leaking. Henry thought, now I have diarrhea. He almost took an anti-diarrhea pill. That could have made the situation worse, because Henry did not have ordinary diarrhea. He had a hard stool blockage and liquid stool was leaking around it. That is one of the most important warning signs in this entire video. Watery leakage with rectal pressure and inability to pass normal stool can be overflow around impacted stool. If you remember only one sentence, remember this. Diarrhea does not always mean the bowel is empty. Sometimes it means something is stuck. Now let us talk about the symptoms. The first symptom is the feeling of blockage. You feel like stool is there, but it will not come out. You may feel rectal pressure, a heavy sensation, a deep fullness, a constant urge. But when you sit, nothing happens, or only a little comes out. The second symptom is incomplete emptying. You go to the bathroom, but you still feel full afterward. You feel like the body did not finish. That can happen when stool remains trapped in the rectum. The third symptom is watery leakage. This is the symptom that confuses people most. Liquid stool can leak around hard stool and come out as watery discharge. People think they have diarrhea, but the real problem is constipation with blockage. The fourth symptom is lower abdominal pain or bloating. As stool builds up, gas and pressure can build behind it. You may feel swollen, tight, crampy, heavy. The fifth symptom is rectal pain. The rectum is stretched and irritated. The tissue may become inflamed. Hemorrhoids may flare. Small tears may hurt. The sixth symptom is lower back pain. This surprises people. But the rectum, pelvis, bladder, and lower back share nerve pathways and tight anatomical space. Pressure in the rectum can refer discomfort into the lower back, hips, or pelvis. The seventh symptom is urinary trouble. The rectum and bladder sit close together. If the rectum is stretched with hard stool, it can press on the bladder or urethra. You may feel like you need to urinate often. You may pass only a little, or you may struggle to urinate. If you cannot urinate, that is urgent. Do not wait. The eighth symptom, especially in older adults, is confusion or unusual agitation. This is important for family members and caregivers. An older person may not say, "I feel stool stuck in my rectum." They may just seem different. Restless, irritable, confused, weak, not eating, more tired than usual. If this happens, one of the questions should be, when was the last real bowel movement? Not a smear, not a small leak, not watery discharge. A real bowel movement. That question can change everything. Now, who is most at risk? Older adults, people who are bedridden, people who sit most of the day, people with Parkinson's disease, people with stroke history, people with dementia, people with diabetes-related nerve problems, people using opioid pain medicines, people taking iron or calcium supplements, people on certain antidepressants, people taking some allergy medicines, people taking some bladder medicines, people with poor fluid intake, people who ignore the urge to go, people who use laxatives irregularly and then stop, people who have had constipation for years and think it is normal. It is not normal to suffer silently. Constipation may be common, but that does not make severe constipation safe. Now let us talk about what not to do. First, do not keep straining. Straining hard can worsen hemorrhoids, cause rectal tears, raise pressure in your chest and belly, and make you lightheaded. If you feel blocked and nothing is moving, pushing harder is not the answer. Second, do not take anti-diarrhea medication if you feel blocked. If watery stool is leaking around a blockage, slowing the bowel can make the impaction worse. Third, do not take repeated laxatives without guidance when you suspect stool is stuck. Some laxatives may not help a true rectal impaction. Some can cause cramping. Some can be unsafe in kidney disease, heart disease, dehydration, or bowel obstruction. Fourth, do not try to dig stool out yourself. I know people do this when they are desperate, but it can cause bleeding, tearing, infection, and severe pain. Manual disimpaction, when needed, is a medical procedure. It should be done by trained professionals. Fifth, do not wait if red flags appear. Waiting is what turns a manageable problem into an emergency. Now let me give you the safe action plan. If your symptoms are mild, you are passing gas, you have no severe pain, no vomiting, no fever, no swollen hard belly, and you do not feel a hard blockage in the rectum, then you may be dealing with ordinary constipation. In that case, fluids if allowed, gentle movement, warm drinks, fiber from food, and a regular bathroom routine may help. You can also ask a pharmacist or clinician about safe over-the-counter options based on your age, medications, kidneys, heart history, and symptoms. But if you feel stool stuck in the rectum, if several attempts have failed, if you have rectal pressure, watery leakage, increasing pain, or it has been several days without a meaningful bowel movement, call your doctor or urgent care. Do not wait until the abdomen is swollen and painful. Do not wait until you are vomiting. Do not wait until you cannot pass gas. And if you have severe symptoms, go now. Now let me make the emergency signs simple. Go to urgent care or the emergency room if you have severe or worsening abdominal pain. Vomiting, fever, a swollen or hard belly, blood from the rectum, black stool, inability to pass gas, inability to urinate, fainting, confusion, severe weakness, severe rectal pain, or constipation that is new, severe, and unusual for you. These are not symptoms to manage casually. These are evaluation symptoms. Now, if you do seek care, what will happen? The clinician will ask when you last had a real bowel movement. They will ask whether you are passing gas. They will ask about vomiting, pain, bleeding, medications, surgery history, colon cancer history, and your usual bowel pattern. They may examine your abdomen. They may perform a rectal exam. I know that sounds uncomfortable, but it may be the fastest way to confirm whether stool is stuck low in the rectum. They may use imaging if they are worried about obstruction or severe impaction. Treatment depends on what they find. Sometimes medical suppositories or enemas are used. Sometimes oral medicines are used. Sometimes manual disimpaction is needed. Sometimes the bigger issue is not stool impaction, but bowel obstruction, inflammation, a narrowing, or another condition that needs different treatment. That is why guessing is risky. The right treatment depends on the right diagnosis. Now let us return to Henry. When he finally got evaluated, the cause became obvious. Pain medication slowed the bowel. Iron hardened the stool. Less water dried everything out. Less walking slowed the colon. Fear made him wait. Straining made him sore. And the watery leakage confused him. Once the blockage was treated and the cause was addressed, he did not just feel relieved. He felt angry. He said, "Why did nobody tell me this could happen?" That is why this video matters. Most people are warned about heart attacks, strokes, blood pressure, sugar, cholesterol, but nobody teaches older adults how dangerous severe constipation can become. And because the topic feels embarrassing, people suffer in silence. That silence is what I want to break. Now, clearing the blockage is only half the story. If you do not fix the cause, it can come back. And repeated fecal impaction can become a cycle. Each episode stretches the rectum. Each episode weakens normal sensation. Each episode makes it easier for stool to build again. So prevention matters. Let us build the prevention plan. First, hydration. Stool needs water to stay soft. Many older adults do not feel thirst strongly, even when the body needs fluid. So do not wait until you feel thirsty. Drink regularly through the day, unless your doctor has told you to restrict fluids because of heart failure, kidney disease, or another condition. A morning glass of water may help trigger bowel movement for some people. Warm drinks may help. But if you are on fluid restriction, follow your doctor's guidance. Second, fiber. Fiber helps hold water in stool and supports regular movement. Good sources include vegetables, fruits, beans, lentils, oats, whole grains, nuts, and seeds. But increase fiber gradually. If you suddenly add a lot of fiber while you are already backed up and not drinking enough, bloating may get worse. And if you suspect a blockage, do not try to force it with a huge fiber load. Fiber is best for prevention and regularity, not for bulldozing through an impaction. Third, movement. The bowel is muscular. It moves stool forward through rhythmic contractions. Your body movement helps bowel movement. A short walk after meals can help. If walking is hard, do chair exercises. March in place, do gentle torso twists, stretch, move your legs. The goal is not a hard workout. The goal is daily stimulation. Fourth, respond to the urge. Do not ignore the urge to go. Many people delay because they are busy, traveling, embarrassed, or using an unfamiliar bathroom. But if you ignore the signal repeatedly, the body may reduce the signal. Then stool sits longer, then it dries, then constipation worsens. When your body gives the signal, respect it. Fifth, build a routine. The bowel is often more active after breakfast. This is called the gastrocolic reflex. So pick a regular time, often 15 to 30 minutes after breakfast. Sit calmly. Use a footstool if helpful. Do not strain. Give your body 5 to 10 quiet minutes. Do this daily. The bowel can learn rhythm, but only if you repeat the routine. Sixth, improve toilet posture. Modern toilets put many people in a position that makes passing stool harder. A small footstool can help raise the knees above the hips. Lean forward slightly. Rest elbows on knees. Relax the belly. Breathe slowly. Do not hold your breath and push hard. This position can help the pelvic floor relax more naturally. It is simple, but for some people, it makes a real difference. Seventh, review your medications. This is one of the biggest points. Ask your doctor, could any of my medicines be causing constipation? Pain medicines, especially opioids, iron, calcium, antidepressants, antihistamines, bladder medicines, blood pressure medicines, supplements. Do I need a bowel plan if I must stay on these medicines? Do not stop medicines yourself, but do ask. Sometimes constipation will not improve until the medication cause is addressed. Eighth, be careful with stimulant laxatives. Some stimulant laxatives can be useful short-term, but using them often without medical guidance can create problems. If you rely on laxatives repeatedly, tell your doctor. You may need a safer long-term bowel plan. That plan may include diet changes, fluid strategy, movement, osmotic laxatives, prescription medicines, pelvic floor therapy, or evaluation for an underlying condition. The right plan depends on the person. Now, I want to speak directly to caregivers. If you care for an older adult, bowel tracking is not optional. It is safety, especially if the person is bedridden, has dementia, Parkinson's disease, stroke history, chronic pain, diabetes, or takes constipating medication. Do not wait a week. Write down bowel movements. Watch for appetite changes. Watch for abdominal swelling. Watch for watery leakage. Watch for urinary trouble. Watch for agitation. Watch for new confusion. Ask gently, when was the last real bowel movement? If it has been several days and they are uncomfortable, call the clinician. If there are red flags, get urgent care. Do not be embarrassed for them. Fecal impaction is a medical condition. It deserves medical attention. Now let us talk about shame. This is where many people get hurt. They do not call because they are embarrassed. They do not tell their children. They do not tell the nurse. They do not tell the doctor. They keep sitting in the bathroom alone, trying again and again. Please hear me. There is nothing shameful about the digestive system. The rectum is part of the body. The bowel is part of the body. Constipation is not a character flaw. Fecal impaction is not a personal failure. It is a medical problem, and medical problems should be spoken about clearly. If you would ask for help with chest pain, ask for help with severe bowel blockage. If you would seek care for trouble breathing, seek care when you cannot pass stool and your body is warning you something is wrong. Now let me give you a simple decision guide. If you are mildly constipated, comfortable, passing gas, not vomiting, not severely bloated, and not in severe pain, start with gentle measures and ask a pharmacist or clinician what is safe. If you feel stool stuck in the rectum, have repeated failed attempts, watery leakage, rectal pressure, or several days without a real bowel movement, contact your doctor or urgent care. If you have severe pain, vomiting, fever, a swollen hard belly, no gas, bleeding, black stool, confusion, inability to urinate, fainting, or you look seriously ill, get urgent care now. That is the safest framework. Now I want you to remember the phrase real bowel movement. This matters. A smear is not a real bowel movement. A little watery leakage is not a real bowel movement. A few small pellets may not mean the rectum is empty. A real bowel movement means meaningful stool passed and pressure improved. If pressure remains, fullness remains, and the urge remains, the problem may still be there. Now, what should you say to your doctor? Use these words. Doctor, I feel like stool is stuck in my rectum, and I cannot pass it normally. I am worried about fecal impaction. I have been straining, but it is not working. I need to know whether I need an exam or treatment. If you have watery leakage, say, I am leaking watery stool, but I still feel blocked. Could this be overflow around impacted stool? If you have urinary symptoms, say, I am having trouble urinating or only passing small amounts. Could rectal pressure be affecting my bladder? If you take constipating medications, say, could any of my medicines be slowing my bowel, and do I need a bowel prevention plan? If you are calling for a parent or spouse, say, they have not had a meaningful bowel movement in several days, and now they are uncomfortable, weak, confused, or leaking liquid stool. Could this be fecal impaction? These words help the clinician understand the seriousness. Now let us bring everything together. Stool stuck in the rectum is not ordinary constipation anymore. It may be fecal impaction. It can cause rectal pressure, pain, bloating, watery leakage, urinary symptoms, back pain, and in older adults, weakness or confusion. It can become dangerous if ignored. The first rule is stop straining. The second rule is do not mistake overflow leakage for ordinary diarrhea. The third rule is do not self-treat aggressively when red flags are present. The fourth rule is seek medical help when symptoms are severe, persistent, or confusing. The fifth rule is prevent it from returning by fixing the causes. Water, if allowed. Fiber, gradually. Movement, routine. Toilet posture, medication review, and early action. Not day 7. Not when you are vomiting. Not when you cannot pass gas. Early. Now, remember Henry. His problem did not begin on the worst day. It began quietly. Less water, less walking, more constipating medicine, ignoring small bowel movements, waiting, straining. Then the body reached a point where it could not fix the problem alone. That is how fecal impaction happens. Quietly, gradually, then suddenly. But once Henry got help and built a prevention plan, he stopped being afraid of the bathroom. He knew what signs to watch. He knew which medicine slowed him down. He knew not to ignore 3 days of trouble. He knew watery leakage was not always diarrhea. He knew when to call. That is what I want for you. Not fear, control, not embarrassment, clarity, not panic, a plan. I am Dr. Adrian. If stool feels stuck, do not keep forcing it. If your body is warning you, listen early. If the symptoms are severe, get medical care. And if this has happened before, do not treat it like a random accident. Ask why it happened. Because the real victory is not just getting through one painful episode. The real victory is never letting it happen again.